Hi, I'm Dr. Lorraine Foley. I'm here to talk to you today about should the difficult airway patient be managed in the outpatient surgery center? I am actually medical director of anesthesia at a Medford ambulatory surgery center right outside of Boston. I do have a disclosure of being the advisory board on the advisory board and consultant for IARS Medical. This is a picture of Boston, right outside of Boston. This was taken near my home during COVID, so you can see how blue the sky was because there was no cars at the time. So today, again, talking to you about do you want to do a difficult airway person that you know has a difficult airway in the ambulatory surgery center. As you can see here in study in 1999, they looked at adverse outcomes in the ambulatory anesthesia at Toronto Hospital. And what they found that really, and reported, is between 0.2 to 0.5%. There are respiratory events, difficult intubations being 0.2%, as well as unplanned intubations, as well as laryngospasms and desaturations, bronchospasms, especially our days today with patients that vape. So these respiratory events do occur. Also looking where I work as well, we do have some GI suites. And, the problem with the malpractice claim showed that actually NORA outside the operating room, there are higher events to compare to the operating room, and mainly due to inadequate oxygenation and ventilation. So you can see that you can get yourself in trouble even during these moderate to deep sedation anesthetics. So the thing is should we do a known difficult airway at an outpatient surgery center? You know that there is a difference between an ASC and the hospital inpatient. We don't have the same resources as we would at the hospital. One, for example, where I am, we do not have a ventilator. So if we needed to intubate that patient or remain that patient intubated at that point in time, it's either we keep them in the OR, but at that point, we'd have to transfer them to the hospital. Secondly, we don't have a chest x-ray if you needed to see what was going on, making sure everything's well, as the personnel. You do not have as many people there as you would normally in the hospital. You don't have the ICU resources or radiology resources or things like that. And seriously, most ASCs try, because they're reimbursed at least 50% less than a hospital for the procedures. They run thin on personnel. So if it's only a 1 or 2 OR, you might only have two anesthesiologists, both in their own room. There is no one else outside to help you. So you really need to think about that as well. The other thing is the patient might tell you, oh, I have a known, I was told I was a difficult airway. Well, you have to decide what kind of difficult airway was that. Do they have a letter that tells them how their airway was managed, or they belong to have a medical alert, or if they don't, to try to find out what their problem was, how was their airway managed, because people have different tolerances of what a difficult airway is. Is it greater than 2 or 3 attempts? Oh, that I did 2 attempts, but I end up using another type of, instead of direct laryngoscopy, I went to video laryngoscopy and things like that. So you really need to find out what their definition, a possible definition of a difficult airway was. There are factors I'm going to go over basically that influence the decision. For me, if I'm going to have this patient come to our ambulatory surgery center, first is the cause and severity of the difficult airway. Second is the type of surgical procedure that patient is having. Is it a shoulder surgery? Is it a back surgery, spinal surgery? Or is it a simple Dupuytren's or carpal tunnel? And then the other thing is making sure, do I have the backup I need? Is the staff or someone experienced enough? Is the perioperative staff experienced to help if there's a situation where there's a difficult airway? And lastly, it's important to know what you have for your devices for a difficult airway management device, which I'll go over. Causes of severity of difficult airway, one obviously is the anatomical reasons of why that patient is difficult. Do they have a receding chin? Do they have a decreased mouth opening that only opens less than 2 centimeters? As well as, is it more the airway passage that they're enlarged lingular tonsils? So even when you can go down and do a direct laryngoscopy, those lingular tonsils will get away so you can't see the vocal cords. Or does the patient have severe redundant tissue, especially in morbidly obese or super morbidly obese patients? Does the patient have some sort of enlarged tonsils or pharyngeal tumor or mass? Or how about if the patient's had surgery of the airway and radiation to the neck? Is that another cause? And that's, let's say that was like 5 years ago that they had a difficult airway, expectoration radiation to the neck. It's only going to get worse. And you have to think about that. Also, the question is cervical spine. Do they have severe rheumatoid arthritis that they have no neck movement, or ankle spondylitis that you have to worry about as well? So unstable cervical neck. And the other part of it is, what is the technical reasons? And this is why it's very, very important for us as anesthesiologists and providers that manage the airway, that we document what the problem was and what we saw. Was the patient difficult bag mask ventilation or moderately difficult that it take 2 persons, an oral airway and a nasopharyngeal airway in place? Was a supraglottic airway device used in that it had a leak and it wasn't sitting well and it was difficult that you couldn't use it? Or was it a difficult direct laryngoscopy with a Miller blade, Mac blade? What view did you see? Or was it difficult video laryngoscope, or both? And then lastly, was this patient, or does this patient have a difficult access for if you had to go from A to D, my last resort of an emergency surgical airway, will I be able to do that? Those are very, very important things to realize, know what you need to do. The ASA difficult airway guidelines came out this year in 2021. And I think I looked at this and I'm like, this is something where if I know that this patient, or sort of highly suspected of the patient being a difficult intubation, and, the thought of that you should perform an awake intubation if they suspected or know of a difficult intubation, and they have one of these of the following is again, the patient difficult ventilation, face mask, supraglottic airway device. Is the patient at increased risk of aspiration? Is the patient impossible that is not going to tolerate any type of episode of apnea? These days, we're doing sicker patients. In 1970s, when the ASCs, ambulatory surgery centers, were done, basically their criteria was an ASA 1 or 2, and the procedures only lasted an hour. That is not this case anymore. Patients, especially with COVID, where there's a backlog of patients that need to have surgery, more and more patients are going outpatient, including total joints and spines. So, and the average BMI, not the average BMI, but the BMI cutoff of ASCs are 50. So, is that patient a difficult intubation that's not going to be able to tolerate any apneic episodes? This other question is, is this expected difficulty? Is there going to be an expected difficulty with an emergency invasive airway? Can you do a surgical cricothyrotomy on this patient, or will you have easy access? And lastly, the other concern is, if you think you can do an awake fiber optic intubation, but is this patient going to really be a cooperative patient? Or is this patient a pediatric patient? I had a case that was presented or was asked to bring brought to our surgery center for a pediatric, a 20-month-old who had a hypomandibular hypoplasia. I had some surgery at 5 months old, was known to be a difficult intubation. And then at 15 months old, had been, the only note that I got from the anesthesia record was that it was a Miller 1 blade and was able to intubate the patient. Well, this patient was coming for bilateral M&T. And, am I going to start an IV on a 20-month-old in a ambulatory surgery center? because I didn't know if this patient would obstruct during mass conduction. Normally bilateral MRTs, you don't start an IV. So why would I do that now and change my practice? So that patient to me was not a candidate to become and go to my ambulatory surgery center. So on top of that, what you really need to also look at, again, as like I said, is the type of surgery that will influence the type of anesthetic technique that you're going to require. You know, again, is the length of procedure going to be long? I mean, because like I said before, it was, usually an hour long, but now procedures can last up to 4 hours. And actually, I've had even ASCs where they've, even been 6 because it's become complicated. What about the patient's positioning? Are they going to be in a beach chair position? Or are they going to be prone with the head down and there might be blood loss, where they take a long time and now there's going to be swelling and edema in the airway? Or if they're going to be in a lateral position for shoulder surgery, very, very important, because if they're using 60 liters of fluid, my concern would be is now they're going to swelling and edema on that patient, and I'm not going to be able to extubate them at the end because there might not be any airway leak at all. Other concerns is this patient difficult intubation and they're coming for the ASC for upper airway surgery, a UPP, tonsils. That is a big concern too. So you need to take all those things in consideration. So other things, again, as I talked to you about earlier, is the availability of a difficult airway management devices. Number one thing, it doesn't matter where you are, OB, GI, you should always have, anytime that we are in any anesthetizing location, should have a difficult airway cart or all equipment available. We're talking, these are things that are also recommended by the ASA guidelines, is oropharyngeal and nasopharyngeal airways, a range of Mac blades and Miller blades, as well as bougies, an intubating laryngeal mask airway, multiple sizes of endotracheal tubes, a fiber optic scope, as well as a video laryngoscope, and an emergency cricothyrotomy equipment that you can do an emergency cric. Because all these, you might not be able to do just one, but a combination of one, using a intubating LMA with a fiber optic scope to be able to secure the airway on that patient, or a video laryngoscope with a fiber optic scope technique as well. So this is important, to make sure that you have this, do you have this equipment in your ASC? The other thing is the experience of the perioperative staff. Number one, as I alluded to earlier, the number of anesthesia staff that is immediately available. So that if you do need because you are going to need a second hand while you're trying to manage this, or is the OR staff and PACU staff, if it's in the PACU for reintubation, are able to help you with this. And in that case, what really needs to be done is you need to make sure that these staff is trained on the equipment so they understand. And lastly, the experience of the anesthesiologists themselves. Are they comfortable enough to be able to do a wake fiber optic or emergency fiber optic or video laryngoscope or a combination of the two? So I think it's very, very important that all is taken into consideration. So the other thing is, okay, you might say to yourself, you know what? It's not a big deal. The patient's a difficult airway, but I'm going to do a nerve block, or, I'm going to do a spinal. So I'm not going to have to worry and deal with that airway. But you have to realize there are failed nerve blocks. There are failed spinals. I can tell you a case that I knew of where the patient was a known difficult intubation for ankle fracture. They did a spinal, the spinal didn't work, and they put the patient off to sleep, and it was not a very good outcome. So you can't rely completely on that. And again, difficult LMA, well, just put an LMA in, not a problem. Well, that person still might be a difficult LMA. And if they go into laryngospasm, why that LMA is, or they regurgitate and aspirate, then you need to secure the airway. So those are the things that you always need to be able to plan, that if something fails, will I be able to still maintain this airway? So is this patient appropriate? I'm just going to go over a couple of cases, for an ambulatory surgical center. She's got a receding chin. For someone like this, I would consider they're having they're having carpal tunnel release, or they're having that or I have a wrist or anything like that, that I might be able to put a nerve block in, but I'm not toward that she might be a difficult airway, but I think I still can maintain that airway. I have the right equipment if I need it. I have easy access to her neck if something occurred. But in this case, if you look at a spectrum, she doesn't seem to be as bad, but you never know, and you need to be prepared. Is this patient appropriate for an ambulatory surgery center? Let's say he's coming for shoulder surgery, arthroscopy. Number one, you can see here, he has no neck. So one, he'll probably have for someone morbidly obese patients, there's like approximately 30% failure rate for interscalene blocks. He has no neck. He would be very difficult. He had class 4 airway, OSA, can't move his neck. I mean, he just turns his whole body. Is this patient, number one, appropriate to come to the OR or an ambulatory surgery center, even for surgery, for shoulder surgery? Definitely not. Definitely would need to be not. Would I consider him even for possibly, carpal tunnel? In this case, this person honestly scares me. Do I think, can I do it? Probably. Do I want to take that chance? Probably not. So, because he could be an uncooperative person, doesn't tolerate pain well, and then you try to snow him, so that's why they put the block in. That doesn't work, or some places do bear blocks. But in this case, this person, I would probably not. I would have them still be at the main hospital to be done. So those are the things that you have to consider. So yes, it's not black and white that you have a difficult airway. And so you can't come to the ambulatory surgery center. It is a gray zone, and you need to take all those things into consideration before that decision is made. The other thing is you need to do is, if you're concerned and you need to know, is either plan to have that patient come in and evaluate that patient before surgery is, or even with nowadays FaceTiming and trying to see the patient. But I do that as well. If I'm concerned, is this patient possibly a difficult intubation, or they have a known difficult intubation, and hearing their story and getting the old records before that patient comes and a decision is made that that patient should be done at the ambulatory surgery center. I hope this helps. Thank you very much. And at the end, we'll be having questions. Thank you.
Hello, thank you very much for the kind invitation to speak at the International Anaesthetic Research Society. My name is Professor Ellen O'Sullivan, and I have no conflicts of interest related to this presentation. I'm a consultant anesthesiology and intensive care consultant at St. James's Hospital and Trinity College of Dublin, Ireland. And I have a special interest in anaesthesia for ENT, head and neck, major maxillofacial surgery. I'm director of the Fellowship in Anaesthesia for Advanced Airway Management. I'm a lead airway advisor for the college in Ireland, and I'm on the board of British Journal of Anaesthesia. I have some national and international roles, and just to mention that we have recently completed the ASA guidelines on difficult airway management. Today I'm going to talk about the use of first or second generation supraglottic airway devices. Doesn't matter which one we use. Now, I'll take you back to this seminal paper in 1983 in the British Journal of Anaesthesia by Dr. Archie Brain. This describes the first supraglottic airway device, the concept and the prototype. And it was in the late 80s, in 1987, really, when the classic LMA became clinically available for everybody to use. We're all familiar with this reusable silicone cuffed classic LMA. And so I think it's a great tribute to Archie Brain, who developed it, and Shandy Verghese, who did a lot of the clinical work on the original LMA, that we have this fantastic device. They were very particular about clinical use of this device and positioning. This is a soft tissue view of a correctly placed LMA with you can see with the cuff sitting between the high eye bone and C7T1. This is a CT scan taken in a cadaver, again seeing the optimal position of the LMA with the cuff sitting between the hyoid and the tip conforming to the anatomy of the hypopharynx and at the level of T1 and plugging the upper esophageal sphincter. It was not until 2000 that the ProSeal was developed. This was the first of this double lumen LMAs. It had an airway and a gastric access, a second seal, and increasing sealing pressures. We have lots of first generation supraglottic airway devices, many of them copies of the original classic LMA, different materials now, disposable, plastic, etc. And then there are also now an increasing number of second generation supraglottic airway devices. And you can see here the protector, the iGel, the ProSeal, and so forth. So the second generation supraglottic airway devices are unique in they have been designed with features to reduce the risk of aspiration. And you will see that you have a drain tube to separate both the respiratory tract, which is in green here, and the gastrointestinal tract, which you can see in yellow. And the idea is to create a higher oropharyngeal leak pressure compared with first generation supraglottic airway devices. And the oropharyngeal leak pressure is the pressure that breaks the seal between the cuff and the pericuff mucosa, often used as a surrogate measure of correct device positioning, with over 25 centimeters of water recommended. The cuff manometers are designed to allow adjustment of intercuff pressure to 40 to 60 centimeters of water. So here we see the original first seal of the kind of classic LMA. Now this is the ProSeal, and you can see the first seal here over the larynx, and the second seal where the tip of the device, the longer tip of the device, fits snugly in the upper esophagus. And again, here you can see the most important advantage of a second generation supraglottic airway device is this, I suppose, double effect where you're snugly, the tip is snugly fitting into the upper esophagus and the bowl is over the larynx. And this gives us the ability to check the correct position, which is very important. Now, if you do this bubble test, you can check if it's an intratracheal position, which can happen, putting in bit of gel on the esophageal outlet, and then when you're ventilating you will get some bubbling, and that's a positive bubble test indicating that the position is incorrect. Equally, if the LMA is not in far enough to the hypopharyngeal position, again you'll get a positive bubble test. So there are 5 steps in checking the position of your supraglottic airway device. First of all, the depth of insertion should be more than 50% of the bite block, which most of the second generation devices have. The gel test done on the gastric outlet bubble test will give you an idea of the position of the tip. Suprasternal notch tap test similarly, and free passage of a nasogastric tube indicates it's in the right position, although this may not be done routinely, and a seal pressure of greater than 25 centimeters of water. How do I know the supraglottic is ultimately positioned properly? You know from your 5-step position test that I just outlined: effective gas exchange, the capnogram, the saturation, and the airway pressure. Now, biggest challenge with supraglottic airway device has always been malpositioning causing poor function. And you see on this diagram here where it's correctly positioned below that, the tip is in the hypopharynx. So again, you will get a positive bubble test. Over here, you have downfolding of the epiglottis and of the tip of the supraglottic airway device. And here you have the tip of the supraglottic airway device down in the larynx. So about 50 to 80% we know from studies have a failed optimal position. Sometimes one gets away with it, but in more difficult circumstances, it's very important. And the ideal is to have no epiglottic downfolding, a good seal, and a no leak. And the optimal position is with the epiglottis abutting on the kind of proximal end of the cuff. Here you see the LMA Supreme, optimally positioned the iGel and the LMA Classic. Which supraglottic should be used for routine low-risk surgery? This was a question posed by Tim Cook and Fiona Kelly from Bath in the UK. They come up with an arbitrary kind of scale, a maximum score of an optimally placed and functioning supraglottic airway device. Good success at insertion, speedy insertion, quality of ventilation, a good seal, aspiration protection, avoiding airway trauma, and avoiding sore throat. And the optimum sum was 22 for each device. And looking arbitrarily at the classic LMA and the intubating LMA, they didn't score as high as things like the ProSeal, the iGel, and the Supreme, with the laryngeal tube not functioning quite as well in these parameters also. So what's the place of supraglottic airway devices in guidelines? Now, in the Difficult Airway Society, we're the first, I suppose, to change their guidelines in 2015 when we published them to include second generation in the optimal for Plan B. That's obviously if Plan A fails and oxygenation via supraglottic is optimal rather than another attempted intubation. Second generation are recommended, and Aintree catheter was also described in this guideline. This is to avoid blind intubation through supraglottic, which is not at all recommended. So the success rate of supraglottic airway incision varies, and particularly if you're using blind techniques with ET tubes and bougies, you have a very low success rate. If you use a fiber optic assisted intubation through a supraglottic airway device, its success increases dramatically. This study from Robert Greif and his colleagues in Switzerland showed that intubation via an iGel blindly has a very, very low success rate. So again, intubation via the same iGel in a randomized trial, comparing this with a single-use ILMA tube, first success rate was 96%. So it's much safer to intubate through a supraglottic airway device using vision, using the fiber optic scope. To facilitate this, I was involved with Peter Charterson developing the Aintree intubation catheter, which is ventilation exchange bougie, fiber optic intubations with the laryngeal mask. Just to have no conflict of interest in that, I do not get any money from this device, but it is a very useful exchange catheter. It's 19 French gauge, 4.7 millimeters internal diameter, 56 centimeters long, with markings from 5 to 35 centimeters. And it is suitable for an ET tube 7 or larger. You can give oxygen through it, continue anesthesia, and ventilate while you're performing this. It comes with 2 rapid fit connectors, a 15 millimeter connector and a lower lock connector, with a swivel adapter to allow you to ventilate while you're intubating through the supraglottic airway device, and side holes for ventilation. You must be very careful when because of the risk of barotrauma when if you're using the connectors, and maximum oxygen flow for insufflation should be 2 liters per minute, like for all catheters. You can load the intracatheter onto a fiber optic scope, a standard fiber optic scope of 3.8 millimeters or smaller, and an ambu scope. The small SIN ambu scope, the grey one, is 3.8 millimeters, and you can place this intracatheter nicely over that and then intubate through your supraglottic airway device. What about the supraglottic airway devices during COVID? We were always very cautious at the beginning, in particular because of the worry of aerosol generation, and many of us use this kind of devices or plastic to particularly extubation. Removal of these devices, so we didn't have any aerosol generation. Now we know that the question is, are supraglottic airway devices aerosol generating? And this was debated at length in the last couple of years, but there was no guidance for supraglottic airway device use. But we have all these other procedures were designated AGPs, and one should wear airborne level PPE, and that's me in my airborne my level PPE for aerosol generating procedures. But there was a lack of evidence, and it was recommended that if you use the supraglottic, it was best to use a second generation supraglottic, and scrupulous attention should be paid to ensuring a leak-free seal, even more than usual. This group, the Safe Airway Society, which is a multidisciplinary society of anaesthetists in Australia, they say, if indicated, again, use a second generation supraglottic airway device, as its higher seal pressure during positive pressure ventilation decreases the risk of aerosolization of virus containing fluid particles. So supraglottic airway insertion may involve putting one's fingers in the oral cavity. Obviously, a period of positive pressure ventilation has the potential of contamination via droplet and aerosol routes. But recent evidence from Australia and Bristol in the UK suggests that that insertion and use of SGA is not aerosol generating. So I'm going to finish with this comment. Is it time to abandon the vintage laryngeal mask and adopt second generation supraglottic airway device as first choice? This was first mooted in an editorial in the BGA in 2015, but I think we would all agree, and I suppose more particularly in the COVID era, that the use of second generation airway devices is better. It doesn't matter which one you use, they are insertion is equally as good as a first. They have a better seal pressure. They are safer when one is ventilating, and also in an emergency situation when one is using a supraglottic airway to rescue the airway, the first choice should always be a second generation supraglottic airway device. So yes, it doesn't matter. Thank you very much for your attention.
Hello, I'm Paul Baker and I'm an anaesthesiologist from Auckland, New Zealand, and I'm the president-elect of the Society for Airway Management. And I'm talking to you today about airway leads and airway teams. Here's my credentials and a few of my conflicts of interest. And I also want to discuss with you the Society for Airway Management special project, which is to establish an airway lead network for the USA. And I want to acknowledge my colleagues from the Society for Airway Management who are working on this project with me. And we have recently published our findings in the British Journal of Anaesthesia. First, I want to draw this to your attention. Many of you will be familiar with the ASA closed claim analysis, and this is the latest version. It was published in 2019. There were several versions published going back over 3 decades. But in this latest version, the authors state that we hypothesize that potentially preventable complications occur with difficult or failed tracheal intubation despite updated practice guidelines and improved airway techniques. And in the report, it is shown that current outcomes for results of airway management, and particularly tracheal intubation, remain poor. The number of claims has not changed significantly over the decades, but outcomes were poorer. And there was evidence of inadequate airway planning and judgment errors. There was also 3/4 of claims exhibited judgment failures, and there were delays due to management of cannot intubate, cannot oxygenate emergencies, resulting in an issue with airway management. So what we have here is a lot of effort being put into new research and publications, resulting in new recommendations and new practice guidelines, trickling down, hopefully, in the ideal world, to the workplace for the practitioner to adopt new knowledge, new skill, and new behavior. And of course, the ultimate goal that all of us want to see is improved patient outcomes. But sadly, it would appear, at least from the closed claims studies in the US, that this is not happening. And I'm sure this is not unique to the United States. So the Society for Airway Management would like to plug that gap and believe that airway leads can help improve the information flow from new research and recommendations down to the workplace. Now, for those of you who aren't familiar with an airway lead is an airway practitioner who promotes safe airway management within their healthcare facility. They implement practice guidelines, ensure the provision and standardization of airway equipment, and they encourage education in airway management. They also oversees audit. Now, this concept is not new. In fact, the first Airway Lead network was established after the NAP4 study in the UK in 2011 and was endorsed by the Royal College of Anaesthetists. Shortly after that network was established, Ireland followed suit and set up their Airway Lead network. Then New Zealand, where I come from, we set up our Airway Lead network, and Australia followed on. So it is the goal of the Society for Airway Management to set up an Airway Lead in as many USA hospitals as possible. And from there, we will set up an Airway Lead network. Looking back at the NAP4 study, which was a massive audit of over 3 million patients in the United Kingdom over 1 year, it resulted in a finding of 184 patients that suffered significant morbidity or mortality or death. A report was published in March 2011 involving 167 recommendations, 3 algorithms, and 24 chapters. One of the recommendations involved establishment of an Airway Lead in every anaesthetic department. That would be an anaesthetist responsible for difficult airway management training. The responsible person, along with departmental colleagues, should develop or adopt protocols for dealing with difficult airways in all areas of the organisation. So that would include not just anaesthesia, emergency medicine, and intensive care, and ensure the purchase of suitable equipment to manage difficult airways, and that regular multidisciplinary training for difficult airway management takes place. So that is the foundation of our current Airway Lead networks that we see in other countries. And that is where this idea has come from and what we'd like to see established in the United States. This is the template that we've developed and we published last month in the British Journal of Anaesthesia. And you can see in the bottom left corner, there is a parent organisation. We propose that will be the Society for Airway Management. They will recruit and invite people to become Airway Leads, and they will collaborate with their hospital management to set up a hospital airway committee. And the hospital airway committee will have representation from anesthesiology, intensive care, and emergency medicine, and any other group within the hospital with an intimate understanding and interest in airway management. Now, the individual Airway Leads in different hospitals throughout the country will form the Airway Lead network. That network is so that Airway Leads can share their experiences, their problems, and their solutions to those problems. And they will also interact with other supporting organizations, such as the Accreditation Council, national colleges, Joint Commission, specialist societies, and hospital management. So the primary leads, just to reiterate, the primary goal of the Airway Lead is to promote practice guidelines, airway equipment, education, and audit. I'm going to go through each of these and give some examples. So here is the latest ASA practice guideline for management of the difficult airway, published in January of this year. The authors were multidisciplinary international airway experts, and they sifted through a vast number of publications and information to come up with an up-to-date, fantastic piece of information for education purposes. As you can see from these infographics, there's a lot of information here. I don't have time to go through this, but this would be perfect for your education purposes within your department and something that an Airway Lead could promote for teaching purposes. Another really important thing for the Airway Lead to tackle is equipment. And I'm talking here about standardization, redundancy, and a culture of safety. Standardization involves getting rid of clutter. You don't want equipment that's been sitting on the side, never used, gathering dust, it's out of date, it's probably broken, and nobody wants it. Get rid of it. You want up-to-date, state-of-the-art equipment that is fit for purpose and will do the job for you. You don't need every single example of every single device on the planet, because that will just clutter up your equipment trolleys. But you do need well researched equipment, and that's the role of the airway lead and the airway committee, to sample equipment and make sure you're getting the best for your department. You do need a range of equipment, but not overly stocked. Now, the flip side of standardization is redundancy. There is a need for some degree of duplication. So, for example, if you have a video laryngoscope and it breaks or something goes wrong with it, you need a fallback position, a second device of equal ability that you can use at a moment's notice. You also need basic things like batteries, you need maybe bulbs, and you may need a range of certain types of equipment such as Goodell airways, oropharyngeal airways, to cope with different sized patients. A culture of safety. This is another vitally important aspect of being an airway lead and promoting in the hospital. Good standards of care for airway equipment. You need to make sure sterility is being done properly. Recommendations from the ASA apply. You need checklists to be put on your airway equipment. You need a difficult airway cart that's well labeled. Everybody knows where it is. There's orientation to that trolley. It has a checklist on it and it has guidelines on it. And you need to make sure there are enough of them if you're in a big department so that you don't have to run huge distances to drag it in an emergency. You also need to comply with international and national standards. Equipment should be fit for purpose. So this is an example of a little study done in the UK where they analysed bougies. And you can see there's a range from 13% to 78% in first pass success. The problem was the first one, the one on the top, wasn't designed with a coude tip, and that had a huge impact on the success rate of that particular device. Education, extremely important. Now, the airway lead doesn't need to do all the teaching, but you can recruit people who are interested in education and airway management, and you can run regular courses, airway hands-on tutorials, simulation tutorials, multidisciplinary groups. You can have journal clubs, you can have animal labs. All this can be done, and it can be arranged by your department and your airway lead. Audit. You can't fix things if you don't know what's broken. So you need to see what's going on in your department. You need to look at the incidence of your complication rates and how to improve them. This is an example of an airway app that you can have on your phone. So if you're involved in a front of neck access procedure, for example, you can add in the relevant information that goes into an completely anonymous international database. And from there, we're starting to understand a bit more about the best techniques to adopt in a front of neck crisis. So here you can see the latest trend, and it is definitely towards a bougie assisted scalpel bougie technique. Now there is some follow-up data from the United Kingdom of the airway leads after the initiation and the NAP4 study. So now most hospitals, in fact, 95% have an airway lead installed, and the others are planning to get one. And 44% of airway leads have changed their practice in response to recommendations from the NAP4 study. The airway leads are getting involved in protocol development, procurement, and multidisciplinary training. So the Society for Airway Management wants to have a partnership with prospective airway leads and lead them to their departments to promote the goals and aspirations of the Society for Airway Management with an airway lead network. We plan to lobby support from influential accreditation authorities in the US. We call for volunteers from the SAM airway management community and also promote airway leads to the wider medical community. We are preparing an airway lead database and a toolkit for new airway leads, training and credentialing. So there is a call out for airway lead volunteers. We want to hear from you. If you want to contact me or the Society for Airway Management, we'd like to hear from you. And thank you very much for listening to what I have to say. And we're open for questions after this group of lectures, I believe. Thank you very much for listening to me.
Maybe we should get started. I'm not sure. I think our chair isn't present. So I think we will just take any questions from anybody in the audience, any participants. There is a chat box at the bottom, which I think you can log your questions in. Or you can just unmute and speak.
Any questions from anyone?
There's a question, I think, for Paul from John Williams. How does one reach out to become an airway lead? And that's a very good question, I think.
Yes. So at the moment, the Society for Airway Management will be the host organisation for this proposed airway lead network and airway leads in the United States. There is a publication in the British Journal of Anaesthesia that occurred in January this year that outlines all of that. But at the moment, there is on the homepage of the Society for Airway Management, you can log your interest and we will respond to that. This system is currently being set up, but we're very interested to hear in anybody who is interested in becoming an airway lead, and we acknowledge that probably a lot of airway leads have been out there doing this work without knowing it. So we expect there will be interest. So that's the mechanism at the moment.
Maybe just to add, we've got that set up in Ireland at the moment, and it really works very well. In the USA, I suppose these institutions are slightly bigger, but I think, Paul, we envisage maybe institutions might work as groups rather than obviously national, because it's a huge continent, but might work with enthusiasts within a kind of a group of like-minded an institution. Is that what's envisaged, Paul, I presume?
Yes, I think that's quite right. So we will be talking to some of those groups and promoting the concept of airway leads within their hospital and the cost benefit of it. And that's ongoing at the moment.
There's another question which probably is for probably both Lorraine, Paul and myself, but it's about kind of SGA, laryngeal mass, so I might answer it. What is the best way to encourage institutions to invest in the appropriate airway devices for safe care? And you mentioned that you still have a lot of first generation LMAs and are encouraged to mainly use these versus the more expensive second generation laryngeal mask. I think this is something we faced as well, because it's obviously much cheaper to have a bit cheaper to have your first generation. I think you have to spell out the advantages, this advantage of second generation supraglottic airway devices, which I hope I did in my talk. The fact that you have an esophageal port that you can check, unlike the first generation, that you know the position is correct, and that if you do have a difficult laryngoscopy and you rescue it, your plan B is you rescue with a supraglottic, you can then intubate through them. It took us a while, but I think by spelling this out and asking them for the second generation, which are getting cheaper, and they're, you know, overall they're not expensive in the overall equipment we do have. Supraglottic airway devices are getting cheaper and cheaper, and I would suggest you just keep demanding them, and you will get them, and pointing out that they are safer. They are safer, particularly in a failed airway, that you can check your position. They're safer in obese patients, because again, I use them a lot in obese patients, and it avoids having to maybe intubate those obese patients, because if you get a very good seal, they work extremely well. I suppose the iGels are slightly cheaper than maybe the Pro Seals, which are, I mean, we don't use now because they were reusable, and we don't use reusable kit. But I don't know if Lorraine wants to tell me if you have the reusable Pro Seals in America.
Yes, so we have they're called Supremes. The reusable Pro Seals are Supremes.
Can I just say something about the Supremes though? You can't intubate through Supreme. So I want to say that one of the criteria is to be able to intubate through a supraglottic. So we don't use a Supremes at all, but the ProSeals, there is I think a disposable ProSeal now, which is different to a Supreme. Yeah, okay.
So I actually would like to comment on this as well, just being because I'm, you're being in Ireland and Paul being in New Zealand. So basically for you, in order to, what you need to do is to get the second generation, especially now with the new 2022 ASA guidelines, is you showing them that this is because they want publications, because then if you ask and show it and put it in writing, it puts the hospital at risk as well if something happens to a patient because you don't have a second generation LMA. So what I would do is basically most hospitals, they have a whole thing of setting up what's called subjective, objective, and then application. So your subjective is basically stating that, first generations are not as safe as the second generation, showing the publication and a couple of publications, including, from DAS, from the ASA guidelines, and then saying that this in the long run will be cost effective and safe for safety of the patient is key. That's usually what I end up doing when I need something from the hospital, because it's true. And so they will follow through. So that, that would be the main thing I would do for here in the United States.
That's great advice, Lorraine. Yeah, that's great. Paul, have you anything to comment how you might, how you do it in New Zealand?
There isn't a specific cost involved. We can choose what we like, but it's interesting. I fully understand and endorse what Ellen and Lorraine have been saying, but there does seem to be a bit of a cultural shift as well. So taking cost out of the equation, people still use first generation because that's what they've always used. And it takes a bit of encouragement to teach people the benefits of second generation supraglottic airways. If you ask for them, they're available in New Zealand. So I think if there's a groundswell of a requirement for it and an enthusiasm to use them, you'll find they start to be used more and more. I'm talking about the second generation airways.
So the next question, should we go on to, by Takashi Iri? Has there been data published on iatrogenic COVID infection of anesthesiologists by technique, by strain, by PPE? I can sort of answer, maybe not so much with SARS 2, but SARS 1 out in Toronto. There was many publications on that, on how mainly with SARS 2 when it happened in 2012. It was most of the healthcare workers that actually became sick because of improper PPE and contamination. I think with SARS 2 coming, it's more so maybe in the United States, is that we did have much learning from SARS 1 that you do need proper PPE and also technique of making sure when you're doffing off your PPE that you are not contaminating yourself, and proper doffing as well. So those are the studies that I know of. I'm not sure, Ellen or Paul, what other things. Some studies came out of China at the beginning, where I think it was eye protection was very, very important because they found that they get contaminated. But there, you guys have anything else to add?
No, I think, Lorraine, you're correct. And there was some attempts to look at this, but I think we were quick because of the first SARS infection to realize the importance of PPE. I think we felt, and we had guidelines very quickly on doing kind of rapid sequence intubation and things like that, particularly early on. So I think we haven't as publications such to prove that, but I think it made sense, didn't it?
Yeah, I think we learned a lot from SARS 1.
There's a very good editorial by Tim Cook in Anesthesiology recently that tracks this issue. It shows that a lot of the initial fears, for example, with aerosol, many of the techniques and devices have been shown to be not aerosol generating, or at least very low level of risk. And I think the emphasis should be on PPE rather than worrying about dismantling all of our airway techniques. So it's an interesting review.
That's right. I mean, I think I just mentioned it briefly on my talk on supraglottics, but most of the procedures we thought were aerosol generating as such have been proven not to be, and they were all compared to a volitional cough. And the big thing is not to have patients coughing. A volitional cough is the highest AGP there, and none of the procedures we do come anywhere near it. Even extubating patients shown that they don't have as much spread as volitional coughs. There's 2 centres, one in Australia that's doing a lot of research in Melbourne, and there's another centre in Bristol, and they've set up very good ways of looking at AGP scientifically, and that's their advice. But funnily enough, I don't think they've taken them off the list, a lot of these things off the list of AGPs officially yet, because they have to go through some regulators. But I do think we all kind of avoid coughing patients, and we wear our PPE, but the procedures we do, I think, say airway safety comes first. We shouldn't be using techniques that are, that we're not used to just because, in other words, we shouldn't be not pre-oxygenating. We should not be using high flow if it's necessary, because they're not aerosol generating as far as we know.
Okay. All right. So the next question from Wei Dong Gao. Any new developments, comments on nasal airway devices and managing patients with challenging airways, for example, for endoscopic procedures? I guess I can start. There's actually, 2, as everyone knows, is the high flow nasal oxygenation. The other one, and this I need to disclose, I actually am a consultant for Vyaire, but they also have a nasal CPAP that you can also use for these type of procedures. So either high flow nasal oxygenation, or the nasal CPAP, both can assist in endoscopic procedures for awake intubations on challenging airways. Anyone else want to make a comment? Does that answer your question, Dr. Gao?
It's an important issue. The most common morbidity event, for example, in an awake intubation is hypoxia. So nasal oxygen is a very good way of avoiding that.
Yeah, I think whichever way you give it, you can just give, you can give high flow, but you can just give normal nasal oxygen at a higher flow as well, if you don't have access to high flow nasal oxygen.
Airways allow for testing of their position. Here, the operator performs a suprasternal notch test by pushing on the suprasternal notch. This causes a pressure wave to develop in the esophagus.
I don't know.
The gastroesophageal drain is sealed in the upper esophagus.
We have another speaker, Will Rosenblatt, has joined us.
That's funny.
He must be on another session.
Yeah.
So,
any other questions? I don't see any other questions at all? Would anyone like to ask? It's 11 o'clock. So I think it's 11 now. So the meeting, I think, is done. If no one has any other questions, we hope this was helpful for you. As Paul talked about, we are all members of the Society for Airway Management, Paul being president-elect. I have been past president and executive director right now of SAM, and Ellen was on the board of directors. We hope we have our meeting actually coming in Arizona in September and Tucson. And we hope you go on to the SAM website, look into becoming a airway lead. That would be great. Okay. Thank you very much, all.
thank you very much, everyone.
Thank you.
Thank you.